Hilary Wright, the Vice Chair Education. I'm being Dr. Chakraborty today in his place. I'm going to start with the land acknowledgement. Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. So our presenters today are Dr. Chuck Hui and Dr. Mari Teitelbaum. I knew you weren't a doctor, but I made you an honorary one. Dr. Hui joined CHEO in 2003 following pediatric residency, an infectious diseases fellowship, and a research fellowship at McMaster University. He is the chief of the Division of Infectious Diseases, Immunology, and Allergy, and a full professor at the University of Ottawa. His area of academic work is migration health. He co-founded and is the chair of the largest network of migration health researchers in the world, has consulted with the WHO, IOM, Chuck, is the and the ECDC? European Right. And various governments on migration health policy. He is the chair of the Caring for Kids New to Canada Task Force of the Canadian Pediatric Society. On the RSV side, Chuck has led the regional RSV Prophylaxis program since 2005 and has been a member of the MOH LTC, Ministry of Health and Long-Term Care for Ontario RSV Advisory Group since 2007, and he's been chair of that group since 2020. And Mari Teitelbaum is the Vice President of Strategy, Quality, and Family Partnership and Chief Innovation Officer here at CHEO. Her unique background and her vision for applying innovation to improve healthcare systems make her an asset to pediatrics in Ontario. Mari started her career as an electrical engineer before completing her Masters of Health Administration at the University of Ottawa. And she first joined CHEO at Bourne, Ontario in 2010, and then moved on to her VP position in 2014. Her recent career highlights include just a minor thing of responding to the pandemic with the first pediatric virtual emergency department in Canada, Chief Innovation Officer of the Year, partnering with Sick Kids to put CHEO in the top 1% of digital hospitals in the country, and a sabbatical focused on healthcare transformation at Great Ormond Street Hospital in London, UK. And the title of their presentation today is A Huge Change in RSV Prophylaxis. And I'm very happy to be giving this introduction because as a critical care doctor, I am really hoping that you guys are going to tell me that my life is going to be revolutionized. Thank you.
Press what? Yeah. Oh, okay, sorry. Hide remote control. Okay, sorry. Thank you. Thanks so much for the introduction, Hilary. And it's great to be here in person in Grand Rounds. There's lots of seats and there's muffins and coffee. For those of you who are hiding out in your office multitasking, we know who you are because we can track you, because Mari is the Chief Innovation Officer and Chief Technology Officer, and she has cameras in every one of your rooms. Sorry, no, that's not true at all. Is it? So we will talk about how your life will change, Hilary, and thanks for everybody for coming and for being online as well. If you are wanting to hear about this significant scientific breakthrough in terms of RSV, or if you're wanting to hear about my academic work, you're at the wrong place, sorry. But if you're actually wanting to hear about how evidence gets into policy and how we implement it, then you're at the right place. And I got a thumbs up from Dr. Reisman. That's excellent. Thank you. In terms of disclosures. Again, I'm the chair of the RSV Advisory Group for the Ministry of Health and Long-Term Care of Ontario. I also work on some committees that have some respiratory infection-related things for the province, and Mari has no disclosures. So the objectives for the next 40 minutes or so will be to really describe the significant new intervention in RSV prevention, but recognize the more important policy change that has happened in Ontario, demonstrate how to implement change in the CHEO region, identify important and innovative regional partnerships, and understand each group's part to play in this rollout. To do that, we'll go through a scientific presentation, we'll review a new policy, we'll talk about the intervention and how to make change in CHEO, we'll talk about partners and innovation, and then we'll leave you with some practical things like what to do, where to do it, and when to do it. And so really it is an honor to be up here to give this presentation with you, to you and with Mari, but we really are giving it on behalf of many, many partners that you will hear about, and we will showcase over the time. So it's easy to give a talk on RSV to pediatricians because you know about RSV, you've lived it, you've been up in the middle of the night associated with it. You see patients with RSV in your clinic, you see patients with RSV on the ward. You have to don and doff all your PPE all the time and wash your hands associated with RSV. And you have to, sit by the bedside in the ICU managing patients who are quite sick as well. But I'd like to take a step back and show you what the global burden of disease associated with RSV is. And we know that there's almost a third of pneumonia in the world is caused by RSV. We know that there is almost 3 million hospitalizations yearly related to RSV and over 100,000 deaths related to RSV. And these deaths occur mainly in low and middle income countries. Not only is there morbidity and mortality associated with RSV worldwide, but there's a massive cost associated with it. It's estimated over $3 billion of direct medical costs. And then on top of that, there are non-medical costs and indirect costs. In a high-income country such as ours, we know of RSV as a very common acute respiratory virus, but it causes a significant amount of disease in our setting. 18% of emergency visits and 15% of office visits per year are related to RSV. And there's hospitalization, outpatient visits, and there's death. And we know about the risk factors associated with severe RSV, and those would be prematurity, chronic lung disease, and congenital heart disease. But the problem is that when you look at the patients who are admitted to hospital, 80% of patients who are admitted to hospital do not have any of these risk factors. So we don't do a really good job of targeting prevention. And we know from some data across Canada, this is the Impact Immunization Monitoring Program Active, and Nicole Lasso was on this paper and was our Impact representative. Impact has changed now to a different form. But this was a 5-season study led by Jesse Pappenberg out of McGill University, looking at all hospitalizations in Canada by year of life. And so if you see 5 years, there was 11,000 hospitalizations related to RSV. What's most important from this study is that the vast majority of them were very young and very early in their life. And 23.6% of them actually hit the ICU, and there was 4 days of median hospitalization. So a significant burden of disease, even in high-income countries. So what have we done so far? We'll bring you up to date about what we've been doing up until now. We have a palivizumab program in Ontario, And this is a high-risk program only. Provincially, it was run through the Ministry of Health and Long-Term Care, the drugs branch, the Exceptional Access Program, the Ministry of Health and the RSV Advisory Group that I chaired. Was advising to that. And it was our baby. We had really, really, really tight control over that. I knew exactly how many doses were given in Ontario and where they were given, how much, exact to almost the dollar. And we had significant oversight, and because everybody had to have an approval number. I was previously, I was also an adjudicator. So sometimes when people's criteria were not exactly clear, you would make a referral to the provincial adjudicator, and we would have a back and forth. 13,000 vials per year, almost 3,000 infants immunized per year. Locally, we have a regional RSV prophylaxis program that would include Eastern Ontario, Western Quebec, and Nunavut. We've been running this for a very long time. Previously, it was run by Mark Blaney from neonatology. 300, almost 400 infants a year immunized through that prophylaxis, through that program, 1,000 doses. We have the biggest program in Ontario. So that is what we have up until now. But now we have some new tools for RSV prevention. And that is a new monoclonal antibody. So palivizumab is a humanized monoclonal antibody, but the problem associated with palivizumab is multifold. One is that it's short-acting, so you actually have to have injections monthly during the RSV season. And then the other thing is that it costs a lot of money. So nirsevimab, and this is a kind of a golden age associated with a lot of vaccines, but RSV specifically, there's lots of different prevention kind of programs. There's vaccines, there's monoclonal antibodies, potentially some treatment coming down the pipeline as well. Nirsevimab is, again, humanized immune globulin, a monoclonal antibody that binds to the same target as palivizumab, is the RSV fusion protein, and it has a significantly increased half-life compared to palivizumab. And so you only need one dose during the whole season. And it's no longer weight-based, it's not weight-based, so it's either you're over 5 kilos, you get 100 milligrams. If you're under 5 kilos, then you get 50 milligrams. And so Health Canada gave the no objection letter in 2003, April. We did not implement nirsevimab last year. There was a global shortage associated with nirsevimab. Some countries in the world took up the global supply, like the United States. ACIP, the Academy, the Advisory Committee on Immunization Practices, and the CDC decided to make the recommendation last year for a universal program. And they basically, the US, in addition to Europe, basically took the whole supply up. So then the Health Canada approval was based on three big trials, really looking at premature babies, 29 to 35 weeks, and also late preterm and term babies, in addition to a non-randomized control trial of chronic lung disease and congenital heart disease. And so the benefit was twofold, really. Somewhere between 70 to 80% efficacy against medically attended RSV-associated lower respiratory tract infection, and almost 80% efficacy against hospitalization associated with RSV. So this was consistent based on the premature study in addition to the late preterm study. And this is significant because there's no head-to-head trial compared with palivizumab. However, the large trial that caused us to use palivizumab is the IMPACT trial. It showed a 78% reduction in hospitalization. So much similar to what was previously in the palbociclib trial. The major difference is not only the long-acting, but it also prevents medically attended RSV infection. So it is also, again, in a premature congenital heart disease, chronic lung disease, it's been shown to be safe, and the serum levels are similar to the efficacy trials. So it's thought to be indirect measure of protection. It's a safe product. So this is a comprehensive review associated with all the safety events in the trials associated with nirsevimab. And there was no significant in placebo and nirsevimab in terms of adverse events. And this was consistent across gestational ages and comorbidities. The most common side effects were a bit of a rash, 0.9%, injection site reactions, 0.3%, and fever can occur in 0.5% in the 24 to 48 hours post-injection. Real world effectiveness. So real world, we have the benefit of it being licensed and given in the United States last year, in addition to Europe. And it's actually shown significant reduction in hospitalization and actually in ICU. So this is not in a controlled ICU setting, but this is the real world, warts and all. So 80%, 90% reduction in RSV hospitalization in the United States and in Spain and in France, and 75 to 88% reduction in ICU. Paolo Manzoni from Italy put together all the trials looking at pediatric hospitalization and nirsevimab prevention, whether that be the randomized control trials, the efficacy trials, or the real-world trials, and did a meta-analysis. And basically, they looked at 19 different studies, and they pooled almost 45,000 infants. And basically, the pooled efficacy was 88% against hospitalization admission due to RSV. So I hope that I'm giving you an understanding that, you know, this product, although it's not groundbreaking like CAR-T, it's not, you know, like HIV prophylaxis. Now there's a new medication out there. One injection prevents you from getting HIV for the whole year. Hopefully, Jason will be able to speak to that fairly soon at Grand Rounds. But you know, there's a significant benefit and a real world benefit associated with nirsevimab. So the other thing that was also licensed recently is maternal vaccination. So this is a RSV pre-fusion F protein vaccine. It was trialed in women who were 24 to 36 weeks gestational age. And it showed some benefit in terms of prevention of RSV-related hospitalizations to infants, 57% and 51% for medically attended RSV infection for infants. So this is meant to give maternal vaccination, so stimulating the immune system of the mother, and then passively giving the antibodies to the infant. The important thing to know is, though, that this study and subsequent studies showed that there was waning of immunity over time, and that you need to actually time things properly, because you need to actually have the vaccine in at least 2 weeks before delivery, because otherwise you have to have time to develop the antibodies and to pass them on to the infant. Health Canada gave it an indication or a no objection letter for people who are pregnant at 32 to 36 weeks gestational age. So what's the big deal? Why are we doing grand rounds? This is incremental change. What's the big deal? Well, the big deal is that, now I'll make sure that you recognize the date that this announcement was given, okay? July 25th, 2024. So there was a memo released by the ministry that by expanding the RSV prevention program to include all infants born in 2024 and high-risk children up to 24 months old through the RSV season. We can better protect them from virus and severe outcomes. So there's this big change. Well, what's the big deal? So last season, we immunized just under 2,600 infants, okay? And this is through a very tightly run Ministry of Health Exceptional Access Program, a high-risk program. Now we're talking about going to birthing units. Birthing units haven't done this before. What do birthing units do about immunizations? They have never done immunizations before. There are a lot of birthing units across Ontario. We're talking about primary care giving monoclonal antibodies routinely. They haven't done that before, no. And I don't know if you've seen your primary care doctor, if you have one, but they're pretty stressed out. They got a lot of stuff going on, right? And then high-risk program, you only need one injection. Well, what's the other big deal? So we're estimating that there's probably about 120 to 130,000 infants that will be immunized, and probably estimated about 150,000 doses of nirsevimab will be given in a universal program. And so if you remember, July 25th, which is less than 3 months ago, they decided to kind of drop this on us. Now, I knew about this a little before, but I was sworn to secrecy and could not say anything. But Quebec and Nunavut are the only other provinces and territories that have this year in Canada. So this is a big deal for Ontario. So this is what this program is going to look like this year. It is a universal program. So Beyfortus is nirsevimab, and Abrysvo is the brand name for the pre-fusion protein vaccine given to pregnant individuals. So the monoclonal antibodies, nirsevimab, there's 3 different parts of work. Basically, if you're born in 2024, before the current RSV season, you need to do something. If you're born during the RSV season, you're given it during in the birthing units. And then children up to 24 months of age who have a severe high-risk situation are given nirsevimab. Again, we talked about, yes, Joe.
If they've had previous palivizumab, still eligible, or if they're in that third category?
If they're high risk, yes, we've transitioned from a palivizumab program to a nirsevimab program. There's no longer any palivizumab. We do have some in the pharmacy here, but we're trying to, give it back. There's no contraindication previously having palivizumab for the high risk infants. No, not a problem at all. So it's intramuscular immunization. The timing is basically, we'll talk about it basically as soon as we can get it, because we don't want to pivot, the whole entire province. We cannot pivot the whole entire province. We used to get together with the RSV advisory group and declare when the season starts and when the season ends, but we can't do that when we're talking about like tens of thousands of primary care and hospitals and things like that. So basically, it's whenever we get the product, which we will be getting shortly. We already have the 100 milligram injections. There, on top of that, now we also have a publicly funded, so that's publicly funded, the nirsevimab program, and we have a publicly funded vaccine program for women who are 32 to 36 weeks gestational age. Both of those are free and publicly funded, but you have to be a resident of Ontario. There are reciprocal agreements with Nunavut and Quebec. If infants or patients meet criteria for Nunavut or Quebec, then we can give nirsevimab here. There's ways that we get the money back from that province or territory. This is the high-risk criteria for the second season. Again, it's much unchanged from what it was before: chronic lung disease, hemodynamically significant heart disease, severe immunodeficiency, Down syndrome, cystic fibrosis with respiratory involvement or growth delay, neuromuscular disease, or severe congenital upper airway anomaly. So the other thing to know is that there's a preferential recommendation for nirsevimab. You can offer, it'd be unlikely that people in this room would offer it because we don't see pregnant women too much. But if somebody who's providing perinatal care, you can offer the vaccine to people who are not interested in getting nirsevimab. There's a preferential recommendation of nirsevimab. There's no head-to-head trials, but there's better reduction in hospitalization and medically attended RSV. And on top of that, there's none of this kind of logistics where you actually have to time the pregnancy perfectly. 32 to 36 weeks is only 4 weeks. You have to get it in, and you have to get it in around the time of RSV season. Otherwise, you have a significant waning immunity. So what do we think is going to happen? So this is speaking to what is going to happen in your ICU, Hillary. There's some modeling of from Ontario Health with the assumption of a 90% uptake of patients that are born in season and a 60% uptake for those who are born out of season. So I'd say somebody was born in February, March, April, August. So we need to somehow capture those infants. They need to either go to primary care or somewhere else. We know, and the other assumptions are about an 80% reduction in hospitalization, almost an 80% reduction in ICU. It's estimated that we will see about almost 1,100 acute hospital admissions that will be prevented, almost 2,700 inpatient days avoided, and 141 PICU admissions prevented, and 614 PICU days avoided. And this is really only speaking to the admission to the hospital part, not even speaking to the medically attended RSV that will show up in our emerge. And we know that right now we are in viral surge season. We're at the beginning of everything. Get your COVID shot, get your influenza. Thank you. Yeah. Thank you, Joe. That one. Yes. Get all the prevention you can. Get the Prevnar 20 if you're eligible. Get your zoster vaccine. There's many different things you should get. But there's a potential for a massive impact on the health system. So that's all about the science. But what about the change? So we, and I'm talking about we as physicians here, we are really great at coming up with ideas. We always have the next best thing. And I have lots of next best things. I'm sure many of you have them. But many of them, 90-some-odd% of them, never go anywhere. Because although we have brilliant people who are great on the front lines of innovation, where physicians really fall short is implementation. Because it's a different skill set. And we don't know how to do it. And we don't know what levers to press or to or people to talk to. This is from Harvard Medical School, a program director for leadership strategies. So we know that change in healthcare is difficult, but there are different frameworks to do it. And one is the Cotter's 8-step change model. And I'll just quickly go over it, and we can see if we've done that well through our RSV example. Number one is to create urgency. So having this dropped in July of 2024, not even 3 months before the onset of the RSV season, see? build coalition, and we'll hear about the coalitions that were built, develop a vision, communicate that vision, empower others to act. And we want some short-term wins so that we're happy about what we do, consolidate, and keep the momentum going. And then once you made that change, anchor it so that the change is permanent. So I'd like to actually use the example of this case of RSV prophylaxis about how to implement a change at CHEO. And so not only do we need the framework of how to change, but we really need leadership. And leadership is about recognizing the importance of an idea and fostering partnerships and innovation. So in this situation, what happened was I happened to email Lindy and Tammy on the 7th of July, just a couple weeks before the announcement of the program. I was invited to the Clinical Operations Steering Committee to update on the worldwide blood culture shortage. And at that time, when I was there, Lindy asked me to update on the Ontario RSV prophylaxis issue. And there was clear recognition at that time that this was a big issue and an important issue. And Mari will speak to her conversations at the time and at cost there. And so immediately what happened was there was a small group of people brought together, a huddle to figure out where we should go with this. Mari Pranish, Jennifer Milburn from NSO, and Alicia St. Hill from Bourne, we got together. And then maybe a week after that, the RSV Immunization Steering Committee group, was struck, led by Jen Prue, VP of Partnerships. And that has a significant group behind it with communications, Kids Come First, Bourne, NSO, pharmacy, clinical operations, and ambulatory care. So really significant group that came together. And now I'm happy to turn it over to Mari to really speak to, hopefully take away the curtain to see some of the magic that happens behind the scenes of what we do when we implement.
Nice to see you all, meet some of you for the first time. So just to go back a slide. This is like a moment I'm going to remember for the rest of my career. And it happens because we look at each other and, oh my God, this is the moment. And the reason I say that is, to Chuck's point, you guys do a lot of work at advisory committees, in the building, at the bedside, but there's this whole other world of work, which is essentially, whether you call it acronyms or alphabet soup, there are all these organizations out and about that are trying to make sure that your work scales and that what's happening across the province is equitable. And so the perfect example is newborn screening. Newborn screening has grown to like 40 different things we screen for in newborn, from CCHD, infant hearing, and all sorts of genetic conditions you otherwise wouldn't be able to identify. No one organization can do that on its own. It needs to be managed centrally across the province so that every baby is being tested in the same way. And so that's the model that results in this alphabet soup. This is where I get to play. This is where I get to work. And I love the work of these different organizations. I'm going to walk you through alphabet soup, and then I'm going to try to connect the dots on how they all came together for RSV to try to have an impact in the 3 months that we had. Excuse me. Okay, so where to start? Ministry of Health, I think government who has Ontario Health is actually sort of a subset, an arm's length organization that was created about 5 years ago, just before the pandemic, to coordinate the province a little bit away from the politics. The idea was that it would brought together critical care services and Cancer Care Ontario and e-health, the sort of mothership well around healthcare delivery. Of course, there are advisory tables both at the national and the provincial level that have lots of acronyms as well. So in this case, pulled out NAPC. Then we start getting a little bit closer to home. So the Provincial Council for Maternal Child Health housed at sick kids. Oh, sorry, I have to stay still. It's not my usual way to stay still. Okay. PCMCH, housed out of Sick Kids, has been around for about 12 years, trying to organize, again, the system as it relates to maternal child health. Born Ontario is housed at CHEO, it's where I started, and that's around data. How can we collect information on maternal child health to ensure quality, to drive evidence-based research, to produce dashboards, things like that. And then the sister organization, Newborn Screening, also at CHEO, Pranish's baby, around really having an impact. CMNRP, sometimes I accidentally call it LMNOP, is essentially what the Provincial Council of Maternal Child Health does for the province, CMNRP does for the region. So when practice change comes in, let me think one of the born ones, elective repeat C-sections before 39 weeks. If you want to implement that, you need a connection into every hospital. And CMNRP is the organization that, obviously you know us well. Kids Come First. Does everyone know what Kids Come First is? Health team that brings together like 62 partners across the region. Again, if you want to make a change, you need everybody involved. And finally, Can Immunize. Can Immunize is a super cool app, I guess. The yellow card is the easiest way to think about it. Developed by Koeman and Wilson out of TOH and a local startup. So these are all the organizations I get to play with, and we'll try to organize them a bit. So it really is, so you go from local up through the region, up to provincial, and they're all meant to work together, but as you can imagine, they don't always work together. Sometimes people's priorities aren't exactly aligned and everyone's off doing their own thing. From a Grand Rounds perspective, I did want to just add one piece of something I've learned the hard way, which is how government works. So I've burned myself a couple of times. We think that that MOH or provincial government is really just provincial government, but it's really not. There are two sides of the provincial government. The top half, which is the political side, these are the people who are elected and responsible to their constituents. And then there's a bureaucracy. These are the people who are full-time employees of the government. The bureaucracy works in one way, looks for advice, manages the budget, builds relationship with hospitals. The political side is very different. They're elected in. They're concerned about being elected again. And so while the bureaucracy will do good work, sometimes government has a different opinion, and that's totally appropriate. They are elected, they speak for the people, and they may want to go in another direction. The opposite is also true. Government might have a really good idea, but the bureaucracy doesn't know what to do with it, doesn't know how to implement. So as you are in leadership roles and at advisory tables, it's really important to understand that government isn't one thing. It's this really complicated thing where you talk to the political side and don't warn the bureaucracy, you get your hand slapped, for example. So that's how alphabet soup all fits together. And that's what we wanted to leverage and actually get everyone on the same page around RSV. So to Chuck's point, taking this with 3 months notice and having the impact, no small feat. So we started brainstorming all the things that would have to be true. Well, first, you need the expert opinion to say this is going to happen. So NACI and Chuck's tables and others did that. And of course, you need the funding and the eligibility decision. So that all happened leading up to July 4th. But after that, how are you going to get those hospitals to change practice? Well, Ontario Health did a little bit of it. And then PCMCH got involved and created handouts and things like that. And then CMNRP took it a step further to say, for example, at what point in the postpartum workflow are you going to do this? Parents are going to need information to decide what to do. If we want 90% uptake, we're not going to be able to just say you should do this. We know that there's enough vaccine hesitancy in this world, that there's a huge lift to make parents of a very new baby comfortable. And so here we use newborn screening. So that concept of newborn screening is sending those blood spot cards out to hospitals and have really good relationships with every hospital in the province. So let's use that existing channel into all of those hospitals to actually send them a handout. And well, more than just a handout, but parents need to document that immunization status. So for those kids that are born in season, how's their primary care provider going to know? We know that our vaccine or our data sharing in the province is not great. We're working on it, but we're not there yet. Babies born out of season, where are they going to go? Some of them will be lucky enough to have a primary care provider, but we know many, many don't. So thank goodness, Kids Come First can help us with that. Again, primary care needs to know about it. We've got lots of ways we're trying to account for the fact that we don't have good data sharing. The high-risk babies still need focus. Chuck taught me that on the very first day, is we can't undermine all of the work of the past many, many years just because this new opportunity presents. And most importantly, we need to evaluate this. Is this going to work? And Bourne already collects data from every hospital at every birth, from midwives in the birthing centers, home births, everything. So we get to do a really thorough evaluation of this, despite the fact that we were only given 3 months notice. Good.
Thank you. Thank you very much, Mari, for giving us this quick tour de force of these innovative and incredibly important partners for us to implement any kind of particular change. So what does this look like in our region? So this is our region. So there was a call to action, and this is a great infographic that Mari made, actually. But we have 14,000 healthy babies in our region who are born outside of the viral season, and they need to be immunized. We have 12,000 healthy babies born during the viral season, and they need to be immunized. And we have almost 400 high-risk babies throughout the year, born throughout the year, or even born previous year, and they need to be immunized. And again, so we came together, CMNRP, Bourne, CHEO, NSO, Kids Come First, and to actually implement this. And this is the where, how, and when now logistics. So infants in the second season, meeting high-risk criteria, same process as last year, same process as the year before, same process as 10 years ago. If you meet high-risk criteria, then either you can actually immunize the child or infant yourself, or you can refer to the RSV clinic, rsvclinic@cheo.on.ca. If you're born in season, the birthing units are going to immunize. Massive lift for this massive new piece of work that all these hospitals across our region are going to do, and again, supported by CMNRP, Bourne, and NSO. And if you're born outside of the season and within the 2024 calendar year, primary care, kudos to primary care for stepping up to do this, especially given the significant demands that they have upon them already. And so they're going to be giving their immunizations. However, if there's no primary care, Kids Come First has stepped up, and there's a vaccinate and up-to-date program, and they can go to there or to their local public health units, whether that be Ottawa Public Health is running some localized clinics for patients who do not have primary care, or other public health units in our region. So what is your role? This is the challenge to you, okay? You need to help us out to get to that high level coverage. We need that 60% or higher for infants who are born outside of the season. So the ones that are born in season, we think that we're going to capture most of those. But born outside of the season or high-risk patients, you need to identify them. Okay, identify them. You know the criteria now. You need to immunize them. And we have given you the tools to do that. There's resources right now on CHEO.net. We've put the EPIC order in. It's almost in fully. And there's a CHEO medical directive. It's a corporate medical directive. So you have not signed off on it yet, but you will with your renewal of privileges sign off on this. This is kind of like all the corporate medical directives. So you don't have to ridiculously do every single person in every single division have their own medical directive. So any kind of nurse within CHEO has the ability to actually take this and immunize. So I think we've come to the end of our presentation. It is 9:15, and before we come to the end, I'd like to thank you for your attention, and everybody online. Can't see you online, sorry, but on behalf of the ministry, I've been authorized to thank you for your participation in this implementation of this year, and it's only going to be successful with your implementation. And we're also thanking primary care, massive change, birthing hospitals, massive change, public health, big change, pediatric clinicians or clinicians that see children in the community, massive change. And then the RSV Immunization Steering Committee, we mentioned Bourne, Alicia St. Hill, NSO, Jennifer Milburn, KFC, Kids Come First, Blackburn and Carly Haight, and CMNRP, Darlene Rose, and lots of people within CHEO from communications, and Nick Losier, Andrea McLean, Rob Wilkinson, operations, Karen McCauley, Jennifer Prue, Mari, and pharmacy, Ariane Blanc, and ambulatory care, but also nursing, Allison Gerard. And I'm sure I've missed some people, and I do apologize, but happy to take some things now. So I don't know if you can see it or not, but it's. Thank you. The cartoon says, "Lucky you." Mine's more like a rhinovirus, or in medical circles, respiratory syncytial virus. And the caption underneath says, "Morag made the mistake of telling George she had COVID." So I just put up frequently asked questions to see if there's any, to answer a lot of questions in advance, but happy to take questions, and I cannot see the questions.
Maybe.
Oh, no. Okay, I'm just going to let Rachel help. So it would take Radha's question first, and then.
Thank you, Chuck. Helpful and I guess two questions. One is, what's the date of rollout? And basically, I'm thinking about the ward where we see kids who are admitted on the inpatient unit. There's going to be a number of kids who meet criteria, and so we're going to need to be able to fly them and I guess vaccinate them. Or we think we need a bit of a strategy for that.
Epic and AI.
Right?
Epic and AI.
Yeah. But I guess the question is, if they meet the criteria, there's no form that we need to send to anybody to notify, we just vaccinate. And we need to report it anywhere, or?
Yeah. So lots of good points that you brought up, Radha. Thanks. Sorry, did everybody hear it? So Radha was, so I'm going to repeat all the questions. Radha was asking about, is there a form, what to do in the inpatient wards, and when is the rollout going to happen? Okay, so first things first, rollout is we hope to get the 50 and 100 milligrams. So we hope to get the 50 milligram vials this week. And then once we have it, you're good to go. Okay. And because it's such a long-acting product, we want to just get people, get it into people before the RSV season starts. And typically, we've had this blip associated with COVID, but typically the RSV season starts around the beginning of November. So now is the right time to give it. Okay. We're working and keep an eye on CHEO.net. We're working on trying to figure out whether there's some strategy to help out giving the immunization for ambulatory care and also inpatient units. But basically, any nurse can give it if the patient is stable. There's contraindications or relative contraindications. If the patient's stable, they can give it, and there's a criteria associated with it that's in the medical directive. So the physician doesn't have to write the order. If they're eligible on the wards, then they can potentially get the product. What is the documentation required? There's a whole piece of work associated with nursing practice associated with the appropriate documentation of this product, but it's like a vaccine. And the final thing is that we've changed from a high risk almost drug. Now this is more thought of as a vaccine. It is not a vaccine because it does not stimulate somebody's immune system. You're getting passive immunity. And so therefore we use the word immunization rather than vaccination. And this might be a way that you can have a conversation with your families that might be vaccine hesitant because they're worried about getting something that stimulates their immune system. If that is the issue, don't address things that are not there. But if it's an issue that they're worried about that stimulation, you can say, hey, this is actually passive. We're giving you protection in a passive way. So it is not a vaccination. So I hope I answered all your questions there. Yeah, good.
Any? Yeah. People in the room first. People. Right.
That was great. One thing that was identified here was a question in the first place. The lack of primary care and struggles in our region. Within your infographic and some of the resources, there may be, yes, we will do the encouragement for immunization with families that we may like to think about things. Do we have information on local access, regional access for public health that will administer this? That's going to be the challenge, right?
Yeah, so public health is going to take a very kind of targeted approach to this, and it will only be in certain groups of patients that do not have primary care.
Yeah,
Chuck, question from outside. For high-risk patients in their first year of life, will they still get prioritized by the RSV clinic?
Yeah, so you can send them through to us, but if they have a primary care physician, then they can go to their primary care physician. But you can refer it to us, and because if they're high risk, we want to ensure that they actually get immunized.
We do have a bunch of questions in the chat. Let's just see if anybody else has a hand up, which I don't see. So the first question would be, would the pregnant mothers get the vaccine now as well as the born infants from Sahara?
Yeah, so great question. So there again is a preference to giving the monoclonal antibody nirsevimab because of multiple different things. There's no added benefit of getting maternal vaccine and then nirsevimab, and there's no contraindication to giving you that. But basically, if the pregnant individual received the vaccine, then it's not thought that they need to have the nirsevimab.
And then Dr. Lawrence, she's seen eligibility is greater than 1,800 grams and gestational age greater than 30 weeks. No clarification of whether that's correct at gestational age or gestational age at birth. Can you please confirm which?
Yeah, there's no specific weight or gestational age criteria. I mean, I would suggest in a general sense, and the workflow across the province is that at time working towards almost time from discharge of a level 2 unit, you know, when you're stable, would be best to give it, as opposed to early on. Again, we don't use these products like we previously have indicated to provide infection control within a NICU, because we have infection control for that.
Oh, I think this
I think the next one, Hillary, might be from me.
I think
and I
it's
can
you, Alex. Yeah.
Yeah, I just wondering what proportion of these babies normally represented the circulating virus in previous years, and do you anticipate a drop in the RSV in the entire herd because we're taking out this group of individuals, or is it hard to know?
Yeah, thanks, Alex. I was anticipating multiple different questions, but not that question from you.
Okay, all right, okay, okay, apologies.
The RSV monoclonal antibody is not thought to be an IgA. Well, it is not an IgA monoclonal antibody, and so will not prevent potential infection. So you still could potentially get infected and develop your own immunity. It is preventing a severe disease. So it is unlikely that we're going to have a significant epidemiological shift in RSV overall. There certainly could be a decrease in transmission, but it would be unlikely.
Okay, great. It was more of a self-advertisement for wastewater. I guess we can just track that and just see what happens globally with this introduction. Although the vaccines are also being introduced, so that might confound things. And anyways, I'll stop talking. Thanks very much. Great work.
So thank you.
So, with regard to disease,
Yes.
what is the high risk of? Alex,
But, you know,
Over 60 and any kind, essentially it's any kind of medical condition, heart disease, diabetes, lung disease. Yes, your words, not mine. 60, over 60. But if you don't meet that high risk criteria, you can actually ask for a prescription and get it part of university program. Sorry, I'm going to go back to chat.
Let me make a comment. I think that you're getting a lot of questions about, you know, the content of sort of needing your content expertise on specific questions about the vaccine. But I just wanted to make a comment. This is a great model for how to do something really well. It shows the process expertise of having an executive champion and the content expertise of having an internationally recognized ID / immunization / vaccine expert. And, you know, your model for change, I think you can make simpler. I like the Ernst & Young model, which is burning platform, July 27, vision, how you want to roll it out, and then next steps. And I think you guys did that so well. I mean, you could use this as a teaching case in a business school program. I thought that was really well done. And for people wanting to look at how you not just have an idea, but accomplish the change, I think this is great rounds for that. So
yeah, thanks so much.
You guys.
Thanks, Joe. Joe was reflecting on, for the people online, Joe was reflecting on how it would be an interesting case study for as how to implement change, health programs. Yeah, and again, you know, you need leadership, right, to identify and then to ensure that things kind of work along, move along quickly.
Process expertise.
Yeah.
That's what you guys married. No pun intended.
Great.
I think we're good.
Good.
Probably time. I
Okay.
think that's probably time, guys. So I'll just check. Yeah, we're actually over time. So I'd like to thank Chuck and Mari very much for not only their grand rounds, but their leadership in this. And interested to see particularly the data that comes out of it, Mari, relative to CHEO and also our region. And I'm going to go upstairs and I guess immunize all of the infants in the unit
Excellent.
next week or whenever it's available. Okay, got it.
Thank you.
Thanks.